Hello, everyone. My name is Antonio Gilnagel, and I am a neurologist specializing in pediatric and adult epilepsy at Hospital Ruber Internacional in Madrid, Spain. I want to welcome you to this independent medical education program, which aims to equip healthcare professionals with science-based insights into the pathophysiology, burden, and management of Lennox-Gastaut syndrome. By the end of this mini masterclass video, you should be able to describe the neurophysiological and genetic factors underpinning Lennox-Gastaut syndrome, highlighting key pathophysiological processes. I'm joined today by my colleagues, Dr. Andrea Nissenkorn, Director of Pediatric Neurology at the Wolfson Medical Center in Holon, Israel, and Dr. Takamichi Yamamoto, Director of Seirei Katahara General Hospital in Hamematsu, Japan. Welcome to both of you. Let's begin with a comparative discussion to frame today's topic. When the seizures don't stop, recognizing Lennox-Gastaut syndrome. While all severe forms of epilepsy are a therapeutic challenge, one of the most challenging is that associated with frequent convulsive seizures and sudden falls or drop attacks. A larger proportion of these patients with these types of seizures also suffer neurodevelopmental delay, multiple seizure types that are refractory to anti-seizure medication, and have two EEG features, paroxysmal fast activity and generalized low spike wave discharges, features characteristic of Lennox-Gastaut syndrome. A diagnosis of Lennox-Gastaut syndrome, or LGS, should be suspected in patients with epilepsy onset between the ages of 1 to 18 years, tonic seizures during sleep or sudden falls because of seizures, and those with neurodevelopmental stagnation. LGS is a developmental and epileptic encephalopathy, a disease of the central nervous system starting during childhood, characterized by recurrent seizures and neurodevelopmental delay. Seizures usually begin between the ages of 1 to 8 years and occasionally up to the age of 18. Approximately 3.5% of children with epilepsy onset before the age of 5 years would develop LGS, accounting for 38% of developmental and epileptic encephalopathies. According to a study in 1922, of 613 epilepsy cases, 22 of 58 developmental and epileptic encephalopathies were LGS. In 5.7% cases, LGS evolves from another developmental and epileptic encephalopathy, mostly infantile spasms and West syndrome, but it can arise also from other types of focal or generalized epilepsies. Like other developmental and epileptic encephalopathies that we mention shortly as DEEs, LGS occurs in a developing brain, which in part explains its often devastating consequences. LGS is considered a network epilepsy. Seizures originating in the cortex, frequently in multiple sites or large cortical areas, spread via cortical and subcortical pathways, facilitated by a hyperexcitable thalamus and cortices. This abnormal activity further propagates through the corticoreticular and corticospinal tracts. Lennox-Gastaut syndrome can be recognized by a triad of multiple treatment-resistant seizure types, most commonly tonic, atonic, and atypical absence seizures, plus cognitive impairment or developmental delay, and a distinctive electroencephalographic pattern showing diffuse low spike and wave discharges, which are 2.5 Hz or less in frequency, occurring during wakefulness, and in addition, during sleep, generalized paroxysmal fast activity. Patients frequently experience drop attacks leading to falls. Tonic seizures tend to occur more often during sleep or drowsiness, and atypical absences occur during wakefulness, causing mental obtundation and decreased awareness. Seizures in LGS are often refractory to anti-seizure medication. The etiology of LGS is heterogeneous, with identifiable structural, genetic, or metabolic causes in approximately 2/3 of patients, while the remainder are of unknown origin. Intellectual disability and behavioral disturbances are common and tend to worsen over time. Diagnosis is based on clinical features and EEG findings, with low spike wave complexes below 2.5 Hz being highly characteristic. The syndrome is chronic and long-term outcomes are generally poor with persistent epilepsy and progressive cognitive and psychosocial dysfunction. Current diagnostic criteria require the presence of multiple seizure types, including tonic, developmental delay, and paroxysmal fast activity in a patient with epilepsy onset between the ages of 1 to 18 years, so that we can establish a strict diagnosis of LGS. When a diagnosis of LGS is made, effort should be made to identify the cause through an adequate clinical history with special attention to early brain insults, such as perinatal hypoxic ischemic encephalopathy, neonatal hypoglycemia, neonatal meningoencephalitis, tuberous sclerosis complex, etc. A brain MRI will detect most structural abnormalities. Genetic testing is currently performed since monogenic epilepsies account for many cases of LGS, and their identification may guide medical therapy. Nevertheless, currently, LGS requires treatment with anti-seizure medication. Other anti-seizure medications are also used with valproic acid, often selected as the first-line therapy. There are specific therapies for these syndromes, such as highly purified cannabidiol or Epidiolex, clobazam, fenfluramine, stirpental, rufinamide, and felbamide, which will be discussed in greater detail in episode 5. Now, let's hear how this plays across different healthcare settings.
Thank you, Antonio. In the Middle East, region-specific data on the prevalence and etiology of Lennox-Gastaut syndrome remains scarce. Few population-based studies have been conducted, and national epilepsy registries are largely lacking. Consequently, our understanding of the true disease burden in the region is limited and relies mainly on extrapolation from global figures and clinical experience. Assuming that the prevalence in the Middle East parallels the reported worldwide, the expected number of patients with LGS in Israel, which has a population of approximately 10 million people, would range between 1,000 and 3,000. However, the number of diagnosed patients is considerably lower, estimately at roughly 300. Notably, this figure has doubled or even tripled in recent years. The increase likely reflects increased awareness and recognition of physicians in order to have access to LGS-specific therapies, which have been incorporated into the National Health Basket insurance. Improved awareness among clinicians, particularly of non-drop seizures types, such as atypical absences and tonic seizures, and of electrographic features such as paroxysmal fast activity in addition to slow spike and wave patterns, has significantly increased diagnostic yield. With respect to etiology, secondary causes such as hypoxic ischemic encephalopathy or evolution from infantile spasm or West syndrome are now encountered less frequently in pediatric LGS cases in Israel. This trend may not apply to adults with long-standing epilepsy, but is evident in children currently being followed in tertiary centers. Although systematic epidemiologic data is lacking, several factors probably contribute to this decline. Advances in perinatal care, early and aggressive management of neonatal seizures, and the widespread use of therapeutic hypothermia might have reduced the incidence of post-hypoxic ischemic epilepsy syndromes. In addition, Israeli pediatric neurologists maintain a high index of suspicion for infantile spasm and routinely implement intensive treatment protocols for hypsarrhythmia, likely mitigating progression to LGS. Genetic etiologies appear to be relatively overrepresented in Israel and neighboring Middle Eastern populations. While autosomal dominant variants are recognized globally, our region also has a high prevalence of autosomal recessive disorders, reflecting the impact of consanguinity and endogamous communities. This genetic background increases the likelihood of inherited epileptic encephalopathies and metabolic disorders presenting as LGS. Therefore, maintaining vigilance for inborn errors of metabolism and other recessive syndromes is crucial, as several of these conditions have disease-specific therapies that can substantially alter prognosis if identified early. In summary, LGS in Israel and the Middle East illustrates both the challenges and progress of epilepsy care throughout the world. Although the true prevalence is probably underestimated, diagnostic accuracy and therapeutic access have improved markedly in recent years. Ongoing establishment of national registries and collaborative research initiatives will be essential to better define epidemiologic patterns, elucidate genetic contributions, and optimize outcomes for children affected by this complex epileptic encephalopathy.
Thank you, Andrea. Etiologies are wide-ranging, as Antonio and Andrea described. In Japan, probably decades ago, many patients with Lennox-Gastaut syndrome had a previous history of West syndrome, which is now formally called infantile epileptic spasms syndrome. 30 through 60% of West syndrome was believed to change into LGS, or 20 through 60% of LGS was previously diagnosed as West syndrome. However, there was no scientific research about this transition in Japan, unfortunately. At the present, pediatric epileptologists say that the rate of transition from West syndrome to LGS is not so many. There are several reasons, including early diagnosis and early treatment for West syndrome. Then the number of transitions could be decreasing, but this is merely hypothesis. Therefore, LGS patients without a previous history of West syndrome should be given light on. There are many challenges with this, because etiology is different from case to case, and seizure types are various. Looking across Asian countries, etiology of LGS could be so different, because there are extreme differences in geography and the climate. Parasitic and bacterial infections of the central nervous system are still serious issues in the southern Asian regions. Healthcare systems are also different from country to country. In Japan, Korea, and China, pediatricians, especially epileptologists, could provide adequate treatment for LGS all over the country. However, in some Asian regions with a large population, there is a serious inequality to access to medical care by less epileptologists. Then an educational program like this is very important for general pediatricians and the general physicians who should care for these patients on the front line in some Asian countries. Even in Japan, diagnosis of LGS does not go well in many cases. Symptoms are various, complex, and change with time. There's no typical biomarker such as blood test. We mentioned genetic abnormality before. However, genetic analysis is not perfect. Seizure types are various, including atypical absence, tonic seizure, and atonic seizure, which induces drop attacks or epileptic falls. Seizures often start when patients are infant. Then these symptoms are very negligible, particularly when tonic seizure occur while sleeping. Guardians do not understand these are seizures. When they struggle onto an epileptic center, patients get a standard treatment. But epilepsy centers are not every prefecture. For example, 1 million population are covered by only our epilepsy center, providing long-term EEG monitoring through epilepsy surgery. Access to epilepsy care is the same issue in my country.
Thank you, Taka and Andrea. In Spain, physician knowledge of the diagnosis and therapy of difficult-to-treat epilepsies is usually limited to neurologists specialized in epilepsy, also known as epileptologists, as Taka already mentioned. These specialists typically care for children and adults with LGS. Access to diagnostic tools such as high-resolution brain MRI, including the Harness MRI protocol that has been recommended by the International League Against Epilepsy, anesthesia during MRI, prolonged video EEG monitoring, neuropsychological testing, and proper genetic analysis is improving and becoming more widespread. However, differences still exist among the various Spanish regions, between the public and private sectors, and between rural and urban areas. In general, patients can transfer from one center to another within the public system and within the private sector, but they are not allowed to opt for private physicians or hospitals that have this care covered by the public system. They have to choose whether to go to the public system or use the private out of their pocket or different private insurances. These limitations are creating another significant gap in the quality of care between different socioeconomic groups, as well as inefficiencies in resource allocation. For example, anti-seizure medication is covered by the national health system of each region. However, another barrier and inefficiency occurs here because the national health system inability to pay for anti-seizure medication that is prescribed or filled by a private doctor instead of a physician from the public system. So often families have to visit several physicians to have the cost of their prescription covered by the public sector. Fortunately, sensitivity of this issue is increasing among public family practitioners, and they are granting medication prescribed by private specialists, therefore avoiding having the patient to visit another public specialist and go again through the whole evaluation with the cost that this will include in the system. As we've seen, Lennox-Gastaut syndrome is a complex and heterogeneous epileptic encephalopathy with diverse causes, variable presentation, and significant diagnostic challenges across regions. While progress has been made in improving recognition, genetic testing, and access to LGS-specific therapies, the journey for patients and families is far from over. Understanding the underlying mechanism is only the first step. From this, they need to find a caring physician that has enough time to take care of all the multiple aspects of LGS. In our next episode, More Than Seizures, Understanding the Full Burden of LGS, we shift our focus from pathophysiology to the broader impact of this disorder, exploring how LGS affects not only patients, but also their families, caregivers, and the healthcare system that support them. We'll examine the multifaceted burden of disease, including cognitive, behavioral, and psychosocial dimensions, and discuss strategies to improve quality of life and multidisciplinary care. Thank you for joining us for this masterclass on When the Seizures Don't Stop, Recognizing Lennox-Gastaut syndrome. We look forward to continuing the conversation in the next episode.